Welcome to The Explainer. Today, we're diving into a real master of disguise and endurance. It's a stealthy invader that most of us actually encounter really early in life. And, we usually just assume once it's gone, well, it's gone for good. But today, we're tracking the complete life cycle of this invader, the Varicella-Zoster Virus. In this explainer, we're going to decode exactly how this virus sneaks into our bodies, how it wreaks havoc, and its frankly incredible ability to just hide in plain sight for decades.
All right, so here's our roadmap for today. First up, we'll meet the Varicella-Zoster Virus. Then, we'll walk through the chickenpox infection cycle, followed by severe complications and risks. After that, we'll uncover the sleeper agent, Shingles. Then, it's on to diagnosis and medical treatments, and finally, prevention through vaccination. Let's get into it.
Section 1. Meet the Varicella-Zoster Virus.
So, the Varicella-Zoster Virus, or VZ for short, is a highly contagious DNA virus wrapped up in protective proteins. It belongs to the herpes viridae family. But honestly, the absolute most critical piece of information here is that last phrase, lifelong latency. Because unlike, say, a common cold virus that your system eventually clears out, VZ has evolved this incredibly sophisticated trick to move into your body and literally never, ever leave.
Now, you might be wondering, how does it actually break in? Well, this invader is incredibly opportunistic. It spreads through airborne respiratory droplets, meaning just a simple cough or sneeze from an infected person in the exact same room can be enough to catch it. It can also spread through direct contact with fluid from the blisters it causes, and, though it's rare, from a mother to her fetus. But here's the truly stealthy part. An infected person is actually contagious for 1 to 2 full days before a single spot of a rash ever shows up on their skin. So by the time you realize someone is sick, the virus has already packed its bags and moved on to its next target.
To put that into perspective, just look at this massive incubation window. After day 0, the initial viral exposure, there's this long stretch of 10 to 21 days. That's an average of about 2 weeks where the patient feels absolutely 100% fine. But beneath the surface, the virus is aggressively multiplying. Then we hit that contagious phase just before the symptoms trigger, which is followed by a few weeks where the physical rash erupts and eventually crusts over.
Section 2. The chickenpox infection cycle.
Okay, so this sequence maps out the actual physiopathology of the invasion. Step 1. The virus enters through your respiratory tract and starts replicating. Step 2, it travels to the regional lymph nodes to really build up its numbers. Then, Step 3 is where the alarm bells start ringing. Viremia. The virus essentially spills into the bloodstream in primary and secondary waves, surfing all throughout the entire body. This blood spread leads straight into Step 4, which is that highly visible skin rash. And finally, Step 5. This is its most insidious move yet. The virus retreats from the skin, travels all the way up your sensory nerves, and becomes completely latent in the nerve ganglia.
When that stage 4 skin rash first makes an appearance, medical professionals are actually looking for a very specific visual cue. They call it dewdrops on a rose petal. Now, I know it sounds incredibly poetic, but it hits the nail right on the head for describing the classic look of early chickenpox vesicles. It's essentially a tiny, clear, fluid-filled blister just sitting right on top of a red, inflamed base of skin.
But of course, those dewdrops definitely do not stay that way. The rash goes through a very distinct, intensely itchy progression. It starts out as flat, red spots we call macules, then raises up into papules, fills with fluid to become those vesicles, turns cloudy into pustules, and then finally breaks and dries into crusts or scabs. This whole shebang usually kicks off on the face and trunk before spreading out to the arms and legs. Now here's the key diagnostic feature for any clinician, and honestly a massive headache for the patient. These lesions appear in crops. That means on any given patch of skin, you're going to see macules, fresh vesicles, and crusty scabs all existing at the exact same time in totally different stages of development.
Section 3. Severe complications and risks.
For decades, chickenpox was kind of culturally viewed as this harmless childhood rite of passage, right? But the actual data tells a much more serious story. The stakes vary wildly depending on the host. Healthy kids usually face an uncomplicated run, with the main risk just being secondary bacterial infections from, scratching those itchy lesions. But consider an adult getting chickenpox for the very first time. Their risk of severe varicella pneumonia skyrockets. Pregnant women risk serious maternal complications and even passing congenital varicella syndrome to their fetus. Newborns face incredibly severe, life-threatening neonatal varicella. And for immunocompromised individuals, the virus can literally attack the brain and organs, leading to things like encephalitis, cerebellar ataxia, and sepsis. It's like the invader completely adapts its destruction to exploit whatever weaknesses exist in the host's defenses.
Section 4. The sleeper agent, shingles.
And this brings us to the major plot twist of this virus's life cycle. We really have to ask ourselves, why does the virus come back? Remember step 5 from our infection cycle? The virus didn't just die off when the chickenpox cleared up. Actually, scratch that. It retreated. It traveled up the nerve endings and buried its DNA deep inside your sensory nerve ganglia, usually right near your spinal cord or the base of your skull. And it can just sit there, completely dormant, for 50 or 60 years. But as we get older, or if our immune system takes a hit due to stress or illness, the virus wakes up.
And man, when it wakes up, it looks completely different. Let's compare the two. Chickenpox, the primary infection, is a widespread, terribly itchy rash covering the whole body. Shingles, the reactivation, is a highly targeted attack. The virus travels back down the specific nerve path it was hiding in, resulting in this blistering rash on just one side of the body, a unilateral rash. And rather than just being intensely itchy, shingles causes severe, burning nerve pain. In some cases, this leads to a complication called post-herpetic neuralgia, which means the debilitating nerve pain can last for months or even years, long after the rash itself is totally gone.
Section 5. Diagnosis and medical treatments.
So, how do we fight back? Well, medical intervention scales directly with the severity of the situation. Take a healthy kid with an uncomplicated case. They mostly just need symptom relief and good hydration at home. But shift gears to an adult with severe pneumonia, and the protocol completely escalates to hospitalization and intravenous antiviral therapy. Now, what about a pregnant woman who has merely been exposed to the virus? She might require Varicella-Zoster immune globulin, which is essentially giving her temporary antibodies to fight off the invader before it can even take hold. And for an older adult developing shingles, the absolute key is getting oral antivirals like acyclovir or valacyclovir into their system as early as possible to minimize that nerve damage.
For the vast majority of people dealing with an uncomplicated case, the battle is really all about symptomatic treatment. Keeping the patient hydrated is huge, often using soft foods if the blisters have spread inside the mouth, which happens quite a bit actually. We manage the fever with paracetamol, also known as acetaminophen. We fight the awful itch with calamine lotion, cool baths, and oral antihistamines. Oh, and here's a very practical, absolutely crucial step: trimming the fingernails short. This prevents the patient from tearing open their skin when they inevitably scratch, which blocks those nasty secondary bacterial infections we talked about earlier.
Now, there is a universally stressed warning in pediatric guidelines that we have to mention. Aspirin should generally be avoided in children suffering from chickenpox. Combining the varicella virus with aspirin can actually trigger a rare but incredibly dangerous condition called Rash syndrome, which causes swelling in the liver and the brain. It is a stark reminder that even everyday, over-the-counter symptomatic treatments require absolute precision.
Section 6. Prevention through vaccination. When we look at the consensus from the world's leading health authorities, we're talking the WHO, the CDC, the American Academy of Pediatrics, and the Infectious Diseases Society of America, their evidence-based guidelines align perfectly. Yes, we rely on early recognition, isolating the infected, and using highly accurate PCR tests to confirm the virus is there. And yes, we deploy targeted antiviral therapy for high-risk patients. But their number one universally agreed-upon directive is this: vaccination is the primary prevention strategy.
You know, before the vaccine was introduced, getting chickenpox was just viewed as an unavoidable fact of life, but it resulted in thousands of hospitalizations and completely unnecessary fatalities every single year. While it's true that most healthy kids do recover completely from the natural infection, the varicella vaccine has entirely rewritten the global disease burden. It has dramatically reduced complications and deaths worldwide. It's a real game changer, transforming a viral invader that used to run totally rampant into a highly manageable, preventable illness.
So, we've seen how easily this virus spreads, how aggressively it can attack, and how patiently it waits in our nervous system for a second chance to strike as shingles. The science gives us the tools to close the door on it entirely. So I'll leave you with this thought. Knowing this invader can hide dormant in our nerves for decades, are you and your loved ones fully protected? Thank you so much for joining me on this journey through the evidence. Keep learning, stay curious, and I'll catch you on the next explainer.